I'm from Australia, so I've travelled a long way and I've really enjoyed the last few days of this meeting. I'm a cardiologist, so I've learnt a lot about genetics in the last few days. And what I want to talk about today is sudden cardiac death in young people. Before I do, Australia and Denmark have a very close relationship in many ways. We get a lot of imports from Denmark. We love the cheeses in Denmark. They're very delicious that come to Australia. We love the beer, the Carlsberg beer. We love the pastries. I've probably had more pastries in the last few days than I have in my whole life. Very delicious. Australia don't export much to Denmark, but we do. When we do, they're very important exports. And perhaps the most important export we've sent from Australia to Denmark is your Princess Mary, who of course is an Australian. So this is a time where Australia and Denmark are close in many ways, and it's a real privilege to be talking today. So when you think about heart disease, you often think about this sort of person, somebody who's overweight, middle-aged, physically inactive, high blood pressure, high cholesterol. This is your typical cardiovascular patient. However, we don't usually expect young people to have heart disease, especially young, healthy, athletic young individuals, teenagers, young adults, who may have a genetic fault that leads to cardiovascular disease, which they might not know about at all. And if you look at the last, 25 years, there's been an amazing explosion in our understanding of the genetic causes of heart disease. So these are just some of the diseases where a mutation in a gene directly causes the phenotype. So these are not association aspects of genetics and heart disease. These are genetic mutations causing disease. And so whether you're involved in sort of cardiomyopathies, heart muscle disorders, arrhythmias, vascular abnormalities like Marfan syndrome, metabolic diseases such as FH, and congenital heart malformations, all parts of the heart are affected by genetic abnormalities. And so it's very important to see these genetic heart diseases and learn a bit more about their presentation. So there's some common features of these genetic heart conditions. Most of them are autosomal dominantly inherited. And so when you look after an individual with one of these conditions, you're not only looking after the patient, but you're also looking after their family. So their siblings have a 1 in 2 chance of having the disease, their siblings, and maybe their parents as well. They're generally younger patients and they're often asymptomatic. There's clinical diversity, which is a feature of all these conditions. So within the one family, there may be individuals with no symptoms, all the way through to individuals with heart failure, transplantation, or even sudden death, and they're all in the same family. So a lot of diversity clinically and a lot of diversity genetically. So most of these conditions, there are a number of genes in each of those conditions individually which cause these conditions. And the best approach, and I'll come back to this a bit later on, the best approach to managing these families and investigating these families are multidisciplinary specialised clinics where it's not just the cardiologists involved, there's forensic pathologists, there's geneticists, there's genetic counsellors, there's psychologists, etc., all involved in different aspects of care of these young patients. So the topic of today is on sudden cardiac death, and the reason I show it now is because of all those genetic heart conditions that I've mentioned, basically all of those conditions as a complication can lead to sudden cardiac death. And while it's a rare event, it's often a very high profile event. These are some examples of young people in the sporting arena where when a death occurs, there's a lot of media. We hear it all the way from Australia that these deaths have occurred on a basketball court or a football field. But it also happens in our local communities. These are a couple of young up-and-coming soccer and swimmer in Australia who die suddenly on a particular day. So these are individuals that have got to a level of athleticism. They're clearly elite athletes. They train for many years. They play for many years. But for whatever reason, on a particular day, at a particular hour, they have a cardiac arrest and die suddenly. So what are the causes of sudden death in young people? And I'm going to come back with more data in a moment, but these are generally speaking the causes of sudden death in young people. So you can divide them into structural causes, such as the cardiomyopathies, myocarditis, etc. Importantly, the structural causes, when you do a postmortem in this young individual, the cause is clear. So the heart is thicker, the coronary arteries are blocked, there's inflammation in the myocardium. There is a definite cause at postmortem. The second type of cause of sudden death is the arrhythmogenic or rhythm disorders of the heart, such as long QT syndrome, and this is a short list of some of those conditions. And importantly, when you do a postmortem in these young people, the postmortem is actually completely normal because you can't see the rhythm system of the heart, you can't weigh it, you can't measure it. And so these are unexplained causes of death at postmortem. And so we call this category sudden unexplained death in young people. So I'm going to just touch on two conditions just to give you a flavour of what these conditions are. One structural problem and one electrical problem, just to highlight some aspects of disease. So of the structural cause of sudden cardiac death, hypertrophic cardiomyopathy is a major cause. This is an echocardiographic image of a young person, completely asymptomatic, but his father has the condition. We screened this patient. This is an echocardiogram of the heart. This is the left ventricle. And you can see this is the normal thickness of the heart here, usually less than 10 millimetres, but the thickness of his heart here is about 30 millimetres, 3 times the normal thickness. So hypertrophic cardiomyopathy is fairly common, perhaps up to 1 in 200 individuals. Again, clinically heterogeneous, and the feature of the condition is hypertrophy, thickening of the heart muscle. This is a post-mortem section of a young boy who was running along a beach and died suddenly, showing this very marked thickening of the myocardium. And when you look at a histological level, the myofibers, which should be all lined up perfectly and aligned like a lattice, are all disarrayed. So you see this unusual pattern of the myocytes. And the blue is the interstitial fibrosis you can see here, which doesn't normally exist in the heart. So hypertrophic cardiomyopathy is an example of a condition where there is a structural abnormality which leads to arrhythmias and potentially sudden death. 60 years ago, we called this disease a tumour of the heart, a cancer of the heart, but we now know it's a genetic condition that's caused by a fault in sarcomere genes. So it's now been redefined as a disease of the sarcomere. And you can see here the main genes involved, beta-myosin heavy chain and myosin-binding protein C, the two most common causes of genetic hypertrophic cardiomyopathy. Another condition which fits in the other category is the electrical or arrhythmogenic disorders. So an example of that condition is familial long QT syndrome. So this is a syndrome a bit less common, 1 in 3,000 people, where you have a prolongation of the QT interval on the ECG, which makes the heart more likely to develop rhythm problems of the heart, which can again lead to ventricular arrhythmias and sudden death. Typically, they get syncope, and as I mentioned, sudden death is the major complication. And this disease has been redefined by its genetics as an ion channelopathy. So ion channel abnormalities are responsible for long QT syndrome. This is an ECG down the bottom here showing a prolonged QT with the red arrow. And the problem with this ECG is it can lead to this ECG, which is torsade de pointe, which is a ventricular arrhythmia, which can lead to sudden death if they're not cardioverted promptly. Long QT syndrome, even the genetics now has defined the cause of disease. Here you see the top 3 genes, LQT1, 2 and 3. You see that the first 2 are potassium channel genes and LQT3 is a sodium channel gene. And in the definition of the disease, we don't even need the ECG anymore. I mean, we still do, but even if the ECG is normal, if they carry an unequivocal pathogenic mutation that can lead to long QT syndrome, you've made the diagnosis. So, you know, the impact of genetics in cardiovascular medicine, and what I'm trying to highlight to you, has been a really big impact in terms of diagnosis, and also, I don't have time to go into great detail, but also in management of patients as well. So on the left-hand side here, you see the QT interval in gene carriers of long QT genes, and over a third of them are actually below 440 milliseconds, which is a very, very normal ECG QT interval. So when the QT is above 500, we call it long QT syndrome. But these are normal QT interval, but they carry the gene that can lead to long QT syndrome, and they are at risk of developing disease symptoms in long-term studies. And to show you that the QT gene information not only helps in diagnosis, but on the right-hand side there, you can see that there are differences even within the subcategories of long QT syndrome. So long QT1, usually the death occurs during exercise such as swimming. Long QT2, often through adrenergic stimuli. So to give you an example, I had a patient who was completely well, a 28-year-old lady who was a writer, and she went up to the stage to collect a literary award, and because of the excitement of that award, she actually had a cardiac arrest on stage. She survived and is doing well, but that's the example of long QT2, which is an adrenergic stimulus. Long QT3, mainly deaths occur during rest, and in all of these three subtypes, there are differences in how we treat the patient, what choice of medications. So with that backdrop, a little bit of information about cardiovascular genetics, the genetic diseases, a couple of examples of hypertrophic and long QT syndrome. I now want to talk about sudden cardiac death in the young, a bit more detailed, and what we've done recently in Australia, which I'd like to share with you. And now most people think Australia is down under, but this is how Australians look at the world. So Australia is actually at the top of the world, you can see there, and everyone else is upside down, not us. So that's just us here, and Europe is somewhere down here somewhere. So this is how Australians view the world. So we embarked on a study of sudden death in young people to try and understand what are the causes of sudden death, what are the circumstances of sudden death, and can genetic testing help us in trying to resolve some cases of sudden death? But the first thing we actually had to do before we started the process was to actually have developed best practice guidelines for our colleagues, the forensic pathologists, who in Australia do all the postmortems in these young deaths. And so we established best practice document in about 2008, which was how a postmortem should be conducted in an under 40-year-old. Now, our study focused on young people aged 1 to 35 years, and I'll come back to that in a moment. But these are some of the features in the postmortem best practice guidelines. The first thing to say is, the pre-morbid information is important. So what they were doing before the death, what were they feeling like that day, what were the circumstances of the death, getting a clinical history if possible from the family, getting information from the ambulance officers, the police officers, etc. So getting as much information before you do the postmortem. And then to do the postmortem, this table on the right is a summary of some of the features, but the actual document is about 30, 35 pages because it goes through, in the right ventricle, which parts of the right ventricle you should biopsy to make a diagnosis of ARVC, which parts of the left ventricle, all these different aspects of the postmortem which need to be a bit more careful in a young person. But the key part of this document was actually the importance of collecting a blood sample at postmortem. And that has been a very important part of what we've been doing in Australia and New Zealand, to have that blood sample available. So in Australia and New Zealand today, it is mandated that any young person who dies suddenly, a blood sample must be collected. It may never be used, but it's collected and stored for access for genetic testing. Sometimes there are murder cases where you need DNA evidence and that sort of thing. So it's not just for genetic heart diseases, but other aspects as well. So this was a study we did. This was all sudden cardiac death, and I'll summarize it in a few slides. Obviously it's a longer study, but I'll give you the key points. All sudden cardiac deaths aged 1 to 35 years, all of Australia and New Zealand. It was from 2010 to 2012, and it was prospective. So we collected cases as we went, and it was population-based. So every centre, every state and territory of Australia and New Zealand was involved in this study. So this was the best opportunity to try and collect every sudden death in a 1 to 35-year-old in Australia and New Zealand. And in total, we got 490 cases over that 3-year period. This is the main, finding of the study, which was the causes of sudden death in young people. And what we found was that in 40% of young people who die suddenly, the postmortem gives you an unexplained or unascertained result. So nearly 1 in 2 young people who die suddenly, age 1 to 35, there is no cause, definitive cause found at postmortem. And that was a very important finding because that is a devastating finding for the family. So when, every week, I'm sure many of you in this room, every week we see some parents who have lost a son or daughter. It's bad enough that they've lost that son or daughter out of the blue. In other words, the child's gone to school and never came home, or the child's gone to sleep and never woke up. But then we tell them the postmortem actually didn't show anything, raises a lot of issues with the family. They're suspicious, they're worried that their son or daughter was murdered or poisoned or something foul play was at hand, drug overdose, etc. And so we need to really work on this 40% of unexplained young deaths to try and help these families to understand why their son or daughter died suddenly. Because as you all know, when you see the parents of these young people, they ask you 100 questions, but every parent asks 2 questions in every situation. Why did my son or daughter die suddenly? And how can we stop that happening again to anyone else in my family, my other children? And investigation and genetic analysis and clinical analysis may help answer both those questions. So unexplained deaths were 40%, coronary artery disease, even though it was a low age, was 25%, and then cardiomyopathy 16%, and the list goes on. If you look at the incidence at different ages, you can see that as people get older, the sudden death incidence increases. But overall, as I said at the beginning, it's a rare event, 1.3 per 100,000 people. But the problem is when it occurs, it's an absolute tragedy for everyone involved, including the community. And this shows you that as you get older, most of the deaths are explained. There's sudden cardiac deaths in the blue lines are explained, and the sudden unexplained deaths in red are more prominent in the sort of teenage years. But as you get older, most of the deaths are actually coronary artery disease. What were they doing at the time of death? About 65% were either at sleep or during rest. And this was also an important finding because I showed you an image of sudden cardiac death where everyone was a sports person, but most people are actually dying at sleep or during rest time, watching TV, reading a book, leisurely sitting at home. And so this has important public health implications because I'm sure in Europe there's the same issues in Australia and the US about pre-participation screening of athletes, whether they should all have an ECG. And I know countries like Italy are very promote that. I'm not going to get into that argument, but this data suggests that you might have to, if you're going to screen, you might have to screen everyone because you're going to miss all the athletes because most people are not dying during sports. And so exercise and post-exercise was 11%. This is a table just comparing the unexplained and explained deaths. You see the explained cases here and the sudden unexplained cases here, and looking for differences between the two groups, that 40% of group that are unexplained. And you can see here that firstly, the unexplained cases were younger, age 20 on average. They're more likely to be female, which is very interesting because overall, males outstrip females by 3 to 1. But in the unexplained category, women were more common than men. And of course, what I just mentioned to you, during sleep and during nighttime were also correlated with unexplained death cases. What we then did is we looked at that 40% of unexplained young people who have died suddenly and made the hypothesis, which wasn't a new hypothesis because we'd done this retrospectively before, asked the question, is there a genetic cause of death, particularly arrhythmogenic causes, which won't come up at postmortem? So we did what's called a molecular autopsy. This is an autopsy. This is the utility of that blood sample that I mentioned that every postmortem has to be collected. And so we used the blood sample, extract the DNA, perform some sort of genetic analysis, and then look for a pathogenic cause. Interestingly, during the course of this study, there was such an evolution of genetic testing. So when I wrote the grant for the study in 2009, we were talking about screening 4 genes, which were the main 3 long QT genes and another one which causes a different rhythm disorder called CPVT. That expanded to using panels, excuse me, and then towards the end, we started even doing exomes, although we sort of did virtual panels amongst those exomes. And what we found that in the 113 unexplained cases and a minimum of 59 cardiac genes, we identified a clinically important variant in about 27%. So about a quarter of those 40%, we found a variant which was of significance in terms of potential contribution to death or disease. Not all of these were pathogenic or likely pathogenic, but there was a filtering system we used to try and identify the most likely genetic variants that might be responsible for disease. And so we looked at these genes, and in the paper, all of these genes and mutations and variants are all described because we wanted to share this data with the world. So everything is there for you to have a look at, but mainly molecular autopsy genes, cardiac arrhythmia genes. Interestingly, some absolutely clear cardiomyopathy mutations were also identified, which is interesting because the postmortem didn't show hypertrophy or dilatation or cardiomyopathy. So whether these are gene carriers or non-penetrant individuals, we don't know, but the variants we found in some of those disease genes were absolutely classical genes for hypertrophic cardiomyopathy, etc. So this work is now published. It was recently published in the New England Journal of Medicine, and if you want more information about the genetic findings or any of the details, feel free to have a look. There's a big supplementary section. And the reason I show you the authorship is because of the multidisciplinary nature of the authorship. So on this authorship, we have representatives from all of Australia and New Zealand, but we have cardiologists, we have pathologists, we have genetic counsellors, we have geneticists. We have a range of people involved in the study, and I think it's really important, if there's a message from my talk, sudden cardiac death in the young is a disaster, but the best way to approach these families is with a specialised multidisciplinary approach to care. So the key aspects to summarise all that, sudden death cases, we exclude the non-cardiac causes, you're left with the cardiac causes. Definitive cause in about 50 to 55%, normal at about 40%, and there's a little cohort where there's some unexplained findings which don't fit into a definite category. And if they've got an inherited cause or they're unexplained or they're non-specific, we do both clinical and, if available, genetic screening in all family members. And what I hope I've shown you is that the comprehensive postmortem is a very important first step in this process, and a molecular autopsy may help in some of these cases, and we can talk about that later if need be. I should also impress upon the importance of psychological care of these families. This is work done by Dr. Jodie Ingalls in my group, who's sitting here, and she published this very nice paper in JAMA Internal Medicine, which basically showed, and not surprising to any one of us who's a parent or a sibling of someone, whether you have children or know about children, and that is that there is a very high incidence of a whole range of psychological abnormalities in family members who survive. So, complicated grief, anxiety, depression, post-traumatic stress, all these things are part of the spectrum of looking after these families. And the ones which are most affected, not surprisingly, are the mothers. The mothers, for some reason, I suspect because of that maternal, patriarchal sort of system in a family, are the ones which have most effect. So if we look at the defining of causes of sudden death in molecular autopsy, what I've hopefully shown you is that the molecular autopsy is important in investigation of sudden death. I want to touch now on this lower one, which is sudden unexplained death in epilepsy, because we've now gone on to do some studies, not just in sudden unexplained death, but sudden unexplained death in individuals with a background history of epilepsy. And I just want to show you this because it just shows you the utility of the molecular autopsy. So these are sudden unexplained deaths, predominantly in young people, but the only difference with what I've already talked to you about is that there's a history of epilepsy in these individuals. And so the mechanisms of sudden unexplained death are unexplained and not really sure, but cardiac arrhythmias seem to play a role in the cause of death in these young epilepsy patients. And so we conducted a study where we did again a molecular autopsy, this time in the sudden unexplained death cases, and you can see the genes that were looked into. There's a lot of epilepsy genes known, but also the hypothesis that these individuals might also be carrying an arrhythmia gene mutation which is causing their death. And so we firstly did a gene burden analysis, and I won't go into details, but to compare in a European control set of exomes with the sudden unexplained death of epilepsy exomes to see if there's an overrepresentation of variants in genes in a non-biased fashion in the SUDEP cases versus the controls. And just to show you the top, this is an unbiased look at all across the whole genome. In the top 20 were some very significant genes, DEPDEC5, which is a very important epilepsy gene, but also NOS1AP and KCNH2. Both of these have been previously linked to long QT syndrome and propensity to arrhythmias as well. We then went ahead and did some analysis of those candidate genes, and just to summarize, there were some variants which we think are pathogenic in long QT genes and in epilepsy genes. And so 25% had dominant epilepsy genes, but interestingly, 22% of these epilepsy patients who died suddenly had cardiac arrhythmia or long QT mutations. And again, these two genes were in the top 20 genome-wide. So we think that in sudden unexplained death, there may be a balance between ion channels in the brain and ion channels in the heart, which somehow combine to lead to arrhythmias and sudden death in some epilepsy patients. And this work was published by my colleague, by my team member, Richard Bagnall, who's in the audience also. I'd like to just add one thing, and then I'm going to finish with some prevention approaches in sudden death. But I just want to just mention this paper, which has just come out, which is for those who are interested in this sort of area. Blood is the ideal source of DNA at postmortem. And we always had paraffin-embedded tissues, but with Sanger sequencing, we could never sequence DNA properly in paraffin-embedded tissue because the DNA, as you all know, is nicked and fragmented, and so you can't amplify big regions. But now that we have exome sequencing, the first step of exome sequencing is to fragment the DNA. And so we asked the question, can we do exome sequencing in old, sitting around samples of paraffin-embedded tissue? And the answer is yes. So it's not the ideal source, but we can get good exome information on these paraffin-embedded tissues. And why this is important is because blood is not stored for a long time in Australia in forensic medicine institutes. You need a fridge or some sort of source. But paraffin-embedded tissues in blocks, they're often left in the cupboard for decades. And so some of these examples that we just published show cases being resolved that occurred 10 or 12 years ago, and we had a bit of paraffin-embedded tissue. So the message here is that you can do some genetic analysis with precaution using exome sequencing, using paraffin-embedded tissues. And this is a poster that will be up on the next session at 10:15 by Dr. Richard Bagnall in P05 section. And this has been published in Genetics in Medicine. So the last bit of my talk is just it's sort of a hard topic to talk about sudden death, and it's such a tragedy, but we're making a lot of progress collectively as a society. We're making a lot of progress in many ways. But the big question is, if you can identify a cause of sudden death in a young person, can this help the family in preventing sudden death? In other words, if you know somebody who carries the gene mutation or is at risk of dying suddenly, can we actually stop them dying suddenly? And the answer is an overwhelming yes, because there's many things which I've summarized on this slide which we can do. We can do lifestyle modifications. We can avoid sudden death triggers. Things like bungee jumping. I don't know if it's popular in Europe, but I think no one should do bungee jumping, but especially if you're at risk of dying suddenly because of that adrenergic stimulus. You can put them on tablets like beta blockers, which can prevent sudden death in some people. And you can implant these devices in the chest called an implantable defibrillator, which is a device that sits in the chest with a wire that goes into the heart, and it monitors the heart rhythm. And if the heart rhythm goes into a rhythm that could lead to sudden death, it detects it and delivers a shock directly to the heart of the individual. So just like you see the external shocks, but this is an automatic internal shock called an ICD. There are many crazy things that patients tell you about sudden death triggers, so the history is very important. This is a sport called extreme ironing, where people do ironing in crazy places on cliffs and things like that. I find ironing very boring, but some people find it very exciting, and so this is a real sport. You can look it up, and people do crazy things. So always take a good history when it comes to prevention of triggers. And then this is the ICD, which I mentioned, this device in the chest, and you can see the wire here coming into the heart and sitting in the heart and detecting any rhythms that may lead to sudden death. This is Anthony Van Loo, who has hypertrophic cardiomyopathy and has a device in place. This is him here. He has a cardiac arrest during the game, but he has the device. Is it going to work? Look at his legs to see if he gets a shock. He gets a shock, but does it work? Does it save his life? He gets up. So this is a person that was dead. He would have died. But because of the device that he had in his chest, it detected the rhythm and delivered a shock. So this is what I'm talking about when I'm talking about prevention of sudden death. We can stop people dying suddenly today, but we just have to work out who in the population is at risk of these conditions. And he's actually, if you look at the YouTube clip, he's actually fine. He wants to keep playing. But they put him on a stretcher just to get him off the field. Otherwise, he was going to stay on the field. So a good example of how these devices work. Implantable defibrillators can prevent sudden death in other ways. This is a crazy way. Only in America would this happen. This person was shot, and the bullet actually landed in his defibrillator. So there's the bullet there. So the defibrillator sits on the chest wall, so it went this way, but stopped him dying suddenly because it stopped the bullet going through to his chest. So there's some crazy ways these devices stop sudden death, but this is not a common way that it stops. Well, in America it might be very common, but not in our countries. Just in the final couple of minutes, I've given you a pretty rosy picture of genetics, but obviously this audience knows better than I about the importance of various aspects of genetic testing. Firstly, which test to use. There is a definite relationship between the more genes you look at and the more VOSs that you get, which test to use. the importance of the multidisciplinary approach, the effects of incidental findings, which are very important, and conveying a probabilistic genetic result. And this next slide I've probably shown in every talk I've ever given to a cardiology audience, because you guys get it, but cardiologists don't understand this understanding of probabilistic outcomes. So what we know in this condition, in genetic testing, is that the answer is not a yes-no answer when you get a variant in an analysis. And we have to weigh up, from no mutation to benign, likely benign, VUS, likely pathogenic and pathogenic. Most cardiologists think that the result is a yes-no answer. It is the mutation or it's not the mutation. And the family and the individual, for them, it's a yes-no answer. They want to know if I carried the gene or not carried the gene. But for us as clinicians and researchers, we need to be more careful with this. And so this is clearly the Achilles heel of all genetic testing, to get more information on these variants so that we understand more. Because the more genes we test, the more VUSs we get. So important aspect. And things like the ClinGen initiative is a very important initiative to share data about these mutations and variants so that we can learn more about these variants and whether they cause disease. So, Mr. Chairman and ladies and gentlemen, I hope I've given you a summary of sudden cardiac death in the young, the causes of sudden death, why young people die suddenly, the role of genetic testing, and the hope that we have about trying to prevent these conditions and prevent these outcomes. And I haven't even touched on the public health aspects. So in Australia at the moment, I'm on a campaign to ensure that every Australian knows how to do CPR, a simple thing. You get a driver's license, you know how to use a fire extinguisher. Why don't you know how to do CPR in every individual? I hope that wasn't a sudden death or anything over there. Everyone's good? All good? Okay, just the timing was perfect. So learning CPR, and also the second aspect of public health prevention, of course, is the public access defibrillators, which we're trying to get in schools, in sporting grounds, shopping centres, etc., etc. So in summary, sudden cardiac death in the young is an important complication of a number of genetic heart conditions. There are many issues to be considered relating to the victim, the cause of death, and surviving family, including clinical screening, which I haven't spoken about too much, genetic testing, and of course prevention strategies. Specialised clinics are required which utilise a multidisciplinary approach to care. And the ultimate goal is to, of course, that we're all here today, is the ultimate goal is to prevent sudden cardiac death in young people. I'd just like to acknowledge my team, and I just want to pick out one person, Richard Bagnall, who was the first author of the New England paper, as well as the Annals of Neurology paper and the Postmortem paraffin paper. So he should actually be giving this talk, but I'm honoured to have him in my team, and to Dr. Jodie Ingalls, who did a lot of the psychological work in these families. And as you can see in my group, I have a gender equity problem. There's too many women and not enough men. So if there's any male postdocs out there who want to join me, they can. But of course, females can as well. Thank you very much, and happy birthday to ESHG for their 50th anniversary.